Good evening, everyone, and welcome to our webinar this evening, which is the last event in a four-part series exploring the topic of adapting to a neurodiversity affirmative paradigm in child and adolescent services. The event series has been a joint initiative of Thriving Autistic, the Adult Autism Practice, the Children's Clinic, Childversity, the HSE, and St. John of God's, in collaboration with the Psychological Society of Ireland's Autism Special Interest Group. Tonight, we will be specifically focusing on child autism assessments and reports and how to do them in a neurodiversity affirmative way. My name is Adam Harris, and I am the founder and CEO of As I Am, Ireland's national autism charity, and I'm also an autistic self-advocate myself. Just at the outset, I want to say how exciting and positive I think this series has been, and I think it's a great testament to everybody involved in putting it together and making it a success. I know firsthand, I suppose, the damage that the deficit-based approach to assessment and to autism services can bring to autistic people and our community in general. The barriers to access to services it can present in comparison to the benefits and opportunities that empowering, accepting, and strength-based services can provide. We know that the many autistic people experience a lack of neurodiverse affirmative options when it comes to accessing, be it diagnosis, therapeutic supports, or other psychological services. And equally, we know that many people within the psychology community who are keen to learn more. And that's what these events are all about. And I think they've been a really positive thing so far. So it's great to continue the series tonight. And I'm delighted to be here and to have a chance to be a part of it. Throughout the webinar, you can submit your questions and comments to the Q&A button on the bottom of the screen. Please try to get your questions in throughout the presentation, as we may not have time at the Q&A section to answer your questions. At the end of tonight's presentation at 9 p.m, we will hold a panel discussion with our contributors, and we will try to get to as many of the questions that have been submitted at that point as possible. We won't be able to respond to anyone who may raise their hands, so please make sure you use the Q&A function to put all your questions in. Feel free to get up and take movement breaks as and when you need them. Remember, this is a webinar, so no one can see you or hear you. If you're tweeting, please use the hashtag Neuroaffirmative webinars. That's hashtag Neuroaffirmative webinars. And make sure that you tag at PSI Autism SIG. If you require CPD points from the PSI, please email autism@psychologicalsociety.ie. That's autism@psychologicalsociety.ie after the event. We will do our best to keep this to time, and hopefully it will run as smoothly as possible. Can I remind you, please do not share your attendee link with anyone else. This event is completely booked out, and sharing your link would mean that someone who has registered for the event will miss out on their place. We are recording this event, and the recording will be made available publicly on the Thriving Autistic and the Adult Autism Practice YouTube pages after this evening's event. Before we begin, for psychologists watching tonight, there will be a workshop on neurodiversity affirmative adults assessments at this year's PSI annual conference, which takes place on Wednesday, the 10th of November. So that might be of interest to people, and a date for the diary. And coming in 2022, there will be the release of the Neurodiversity Affirmative Adult Assessment Handbook, which was authored by our presenters tonight, along with their colleague, Dr. Juliana Azevedo. And now, just to introduce tonight's speakers before I hand over to them. Tara O'Donnell-Killen is the founder and practice director of Thriving Autistic. Dr. Maeve Kavanagh is senior clinical psychologist at the Adult Autism Practice and founder and co-director of Childversity. Davida Hartman is the adjunct professor in the UCD School of Psychology, the co-founder of the Children's Clinic, and the clinical director and principal psychologist of the Adult Autism Practice. Jessica K. Doyle is an autistic assistant psychologist, director at Thriving Autistic, the Adult Autism Practice, where she's also an autism consultant and researcher. Without further ado, I will pass you over to our speakers, and I look forward to talking to you again during our Q&A session. Over to you guys.
Thanks so much, Adam. I really appreciate it and really appreciate you joining us today. So we've so much to get through today. We are going to do the contents today, we're going to do a really brief recap of the basics, but we have to say, so if anyone hasn't watched the first webinar, we covered all the basics and we went way over time. So there's a good 2.5 hours of us talking about the basics in a previous webinar that you can find on the YouTube channels of Thriving Autistic or the Adult Autism Practice. So we'd really, really recommend that you go to watch those if you haven't already seen them. We're going to do a really brief recap. Then we're going to be talking about adapting the journey of the autism assessment. We're going to go a bit into the assessment process. We're going to look at the current diagnostic criteria, what's helpful, what's not helpful. We're going to look at the current standardized tests that we use and most people use, again, what's helpful, what's not, what we can do to change them or change them in our reports. We're going to talk about alternative clinical interviews that myself and Maeve and our teams use in our different practices. And we're going to be talking about moving towards new ways of assessing, because at the moment what we're doing is we're working within a paradigm and with tests that aren't ideal, but we're adapting them and we're working with them. But we're going to talk about, well, in an ideal world, what should we be doing if we weren't, for example, using these tests, or if we had a blank slate. We're going to be talking about the feedback session in assessments, and we're going to be talking about recommendations that you can add, neuroaffirmative recommendations, and then going through some sample reports and examples of how you can write a truly neurodiversity affirmative report. And then we're going to try to spend a good bit of time on the Q&A, because I know that a lot of questions probably will come up from what we've talked about. And of course, we couldn't possibly cover everything in a 1-hour webinar, so we're hopefully going to be doing a lot more webinars in the future in various areas related to what we were talking about today, and supporting neurodiversity affirmative therapy with Thriving Autistic. All of those kind of things are coming in future as well. So before we start, it's just really important to know this webinar isn't a how-to guide to undertaking autism assessments. So, you know, we're not going to be going step through step how you do an autism assessment. We're assuming when we know it's not going to be all MDT team members who are currently assessing autism who are attending this webinar, but we're making an assumption for those team members that people are coming with a prior knowledge of recognizing autistic experiences, being able to conduct best practice assessments, you know, able to recognize differential diagnoses, assessing co-occurring conditions like intellectual disabilities and neurotypes, and are aware of diagnostic shadowing, all of those kind of things. So just to be really aware that what we're actually talking about here is a really brief overview for people who are already conducting autism assessments, how they can broadly make them more neurodiversity affirmative. So of course, we can't possibly cover every single step of how to do an autism assessment. It's about adapting them to be more neurodiversity affirmative. So again, all of this covered in webinar 1, but what does it mean? What does it actually mean to be neurodiversity affirmative? So the first most important thing, one of the important things, is that all the supports and the recommendations that target needs and challenges, not the autistic ways of being. And so what very important firstly is being aware of, well, what are the autistic ways of being? So it's really about professionals being aware of those in the first place and doing some research there.
And then looking at the autistic culture, understanding, doing more research, looking at previous webinars, taking trainings by autistic adults and professionals, so that you're coming from a solid grounding of understanding autistic culture, communication, and how to respect people's identity.
Yeah, and another part of being neurodiversity affirmative is a rejection of behavior-based compliance training and neurotypical social skills training and masking. So what that is that when we talk about social skills training, really what we're usually talking about is neurotypical social skills training and training autistic people and children to look and sound like neurotypical people. So to be truly neurodiversity affirmative is to strongly reject that.
Also, to be neurodiversity affirmative is to hold the autistic voice at the center in everything that you do.
Yeah, and then it's advocating for systems and environmental changes. So in terms of recommendations around report, it would not be everything that the child needs to do to change. It's all about advocating, and as a psychologist and as various types of professionals who may be here and listening, that we're also advocating for systems change, because that's where the difference is going to make for these children.
A priority is helping to foster a positive autistic identity. So helping with children and young people's self-identity, that they can be proud of who they are rather than feeling as a failed version of a neurotypical child.
Yeah, and then that there is inherent value in diversity and value in disability. The disability isn't a dirty word.
And finally, we're saying that to be neurodiversity affirmative, you really need to have a solid understanding that all disabled people, including those with significant intellectual disabilities and high support needs, have to be supported and advocated for, given the skills and the tools as much as possible to self-advocate and respect their autonomy. Then we're looking at to reframe autism and the experience and the cultural narrative that's out there at the moment. We're working towards reframing autism as a culture and an identity.
We're also talking about recognizing that there are co-occurring conditions and the impact of trauma within an autistic experience.
And that those who are autistic or have ADHD or other neurodivergences are actually members of a minority group and are subject to minority stress.
Part of reframing autism is about thinking about autism not as a disorder or as a condition, but as a neurotype. That's a valid neurotype in its own right, and that it's part of the wider neurodiversity umbrella.
And then recognizing that there is a divergent developmental trajectory for neurodivergent people. It's not what's written about in the textbooks. The developmental trajectory will be different. Recognizing that we're at the very edge of the science around this and the research. So being aware and awake to that.
And reframing autism is also about understanding that autism is a different way of experiencing the world, but it's a very valid and authentic way of experiencing the world.
And then being aware of individual preferences for communication and interaction, rather than assuming that there is only one gold standard way of communicating and interacting.
So some of the language we use, I'm just going to fly through this. You can come back and look at it again, but we want to talk about things being different rather than disordered or diseased. And we want to talk about individual strengths and needs that account for different internal and external factors such as time, context, energy, mood, and environment, rather than talking about mild or severe or high functioning or low functioning. And we want to talk about speech and language differences as opposed to speech and language difficulties or co-occurring conditions as opposed to comorbidities or comorbid conditions or disorders. We want to talk about characteristics rather than symptoms or impairments or anything else that's kind of medicalized. Or we want to talk about communication differences rather than social impairments or lack of social skills. We definitely don't want to be talking about challenging behavior or disruptive behavior, but instead we want to be talking about communicating or communicating distress. Lack of theory of mind, we shouldn't really be mentioning anymore. We should be talking about double empathy and different communication styles. We need to be talking about needs and challenges accompanying autism rather than difficulties attributed to autism. So rather than because of autism, but with autism. Yeah, I'll go to the next one. Some more, we want to be talking about different or common pattern rather than abnormal pattern. It doesn't, like, people in a team might be all familiar with the ASD, ASC, AS, Asperger's, etc., but we don't want to be talking about autism spectrum disorder or autism spectrum condition. We just want to be saying autism, but we also don't want to be using lots of acronyms, is it? Because they just confuse. We want to be talking about different developmental trajectories and developmental difference rather than developmental delay or difficulties or problematic development. We want to be talking about autism as a neurotype and a neurodivergency, but recognizing that all humans are neurodiverse rather than saying autism is a neurodiversity and neurotypical people are not neurodiverse, because they are, because everyone is. Yep. We want to be talking about attention to detail rather than old theories like lack of central coherence. We want to be talking about thrives with predictability and structure rather than deficits or lacks cognitive flexibility rigidity of thought or even intolerance of uncertainty. We want to be talking about somebody being energetic rather than restless and hyperactive, or talkative, which could be positive rather than talks too much. So kind of taking away all the judgment. Use full words, I said that already. We want to embrace autism and accept autism, accept the autistic experience, and be neurodiverse affirmative, focus on quality of life and internal well-being. We never want to talk about curing autism or fixing autism or treating autism.
So what we've just given you there was a whistle-stop tour really of webinar 1. And as Davita's already said, you can go back and look at that. It's really worthwhile to delve in much deeper into those concepts. Now I just want to talk a little bit about adapting the journey. So for people who are in contact with your service from the very first contact, the very first point that they are in contact with you, whether it's a website or you have a brochure or whatever materials that you use for people to contact you, to be thinking about that first contact point, the written materials. If you want to have them neurodiversity affirmative, then you're going to be looking at making sure that everything that you write is very much strengths-based, concrete, concise, and clear. Ideally, you would have a video introduction or some photos of the people that the family are going to be seeing, of the entry into your service, of the clinic, of the room that the people are going to be in. When you're looking at booking appointments and how those are made, to look at that in terms of accessibility. So we do know that autism is genetic. We don't know specifically everything about it yet, but we do know that there's a large likelihood that children you're working with will have at least one neurodivergent parent. So keeping that in mind, making bookings accessible for them. We also know that the telephone is a large block for access to healthcare and access to appointments for adults, for autistic adults specifically. So having just a range of options where people can make their booking appointments with you. Again, having a clear and accessible cancellation and rescheduling policy. Ideally, again, that it's not just phone calls, but it can be online or email in some way. You can move on to the next one. Then moving on to the actual options with the delivery of the assessment and the work that you're doing with the family, with the child, with the young person. So ideally, to be neurodiversity affirmative, and this is all in our upcoming book, we go into it in much greater depth. I'm just briefly mentioning it here, and we have upcoming trainings on this, but to think in terms of the physical environment of the service and of the space that you're inviting a neurodivergent family into. Have a sensory audit done, again, ideally by As I Am or some autistic professionals who will have a greater awareness of the sensory environment than likely a neurotypical clinician will have. So to get a sensory audit done, to create a sense of safety and a sensory safe environment for the family. If you're providing telehealth options, again, do an audit on that telehealth provision. So you'd be looking at, what's in the background, like here behind me, you can see it's fairly clear. What, is there clutter? What are the sounds? Is your sound system working pretty well? Do you have loud clocks ticking in the background or dogs barking, etc.? And then the lighting, how is the lighting? Is it clear? Is it too bright? You can ask the family, you can assess with them what suits them. Again, this I know is really down to whether it's an option or not, but if you're in private practice, perhaps you can offer outdoor sessions. So perhaps that's something that the family would prefer, the child or young person feel much more comfortable in. And it's really about thinking outside of what the standard and traditional offering has been in terms of adapting and being really, working towards creating a sensory safety and power sharing environment for the people that you work with. In terms of communications, quite a lot of neurodivergent people prefer asynchronous communication. So that really has to be considered. And there are many different really innovative ways of providing delivery options in that way. Thanks, Maeve. And then when you're actually in the session with the family, with the young person, thinking in terms of power sharing. For example, if it's in a room, a physical environment, asking the young person or the family, where would they like to sit? Where would they like you to sit? What way would they like the lighting to be? How about the sounds in the room? Would they like you to change anything up? I think the idea of having a support person there is something we're all fairly familiar with at this stage, but just to mention it because it still is very important if a person would like that. Thinking about your sessions and the duration being more flexible. Some people are happy with the standard 1 hour, perhaps 1.5 hour sessions, but quite a lot could benefit from a 30-minute session or a reduced time. So thinking in those terms, again, with body language, being aware and having done your research and understanding the differences in body language and communication, there may be occasions and need for people, autistic people, to walk around the room while they're talking to you. And I know depending on the age of the child, that can just be a common occurrence anyhow, but being aware with the parents. Body language may not necessarily mean what you would think it means. If a parent is not giving you eye contact or a parent is turning away from you or moving, it doesn't necessarily mean what you might be thinking in terms of putting it up against a neurotypical standard, keeping in mind always that there's a strong possibility a parent may be neurodivergent also. What we find really valuable is to give a summary after each session in the communication style of the person's choice or the family's choice. So that could be by text, by video, or by voice, an audio message, but it's checking in with the person to see what they would like. And that ties in very well with the asynchronous communication style that's very often preferred. So if it's not possible to have asynchronous assessment sessions, then you can at least have a summary of the communication in that style of their choice, so that person can go back, or the family can go back and consider what's happened and read up on that summary.
So just to start thinking a little bit about the actual process, and in terms of adapting and changing how we do the process of an autism assessment, there's a couple of points we just wanted to make in relation to this. So I think the main point is really about it being collaborative from the very start. So I suppose what that means is that you're working in a very shared and collaborative way with a parent, with a family, with a young person, with their expertise. We will never, as clinicians or professionals, we will never have the expertise on a person or an individual that they will have about themselves, but next to that, that a parent will have about their own child. So that collaborative nature of the process is extremely important, and carries through from the very beginning all the way to the very end. It's about making sense of things together. How do we best understand something? Or how do we best understand a person's experience? So carrying on from that, I know we have the word feedback here, but I guess we're reflecting on that quite a lot, and thinking about reframing that, because it isn't in a truly neuroaffirmative approach that's collaborative, it's not about us as a clinician giving feedback to a person. It should be a process of exploring things and making sense of a person's identity together with them. But to use the word that's familiar to us in terms of that idea of feedback and how you share the experience of what you think is part of a person's identity, that process begins the minute the assessment starts. It shouldn't be a moment of, well, now I'm going to tell you the outcome of the assessment and that's a surprise for a person. It should be a process that's evolving from the beginning to the end. And if you're starting a process with that in mind, it gives you a chance to gauge where parents are at, particularly how they're feeling about things, what their understanding of autism is, what their perspective is on that. It allows you to anticipate whether some difficult feelings might be there that they might need support with, and how they might feel about autism being identified. So what that lets you do then is tailor things to their needs and to make that truly collaborative as the process continues. It's also about providing information from a neuroaffirmative framework from the very beginning as you go along in each session, and that creates that sense of this is how we understand autism, this is how we think about it, this is what we're looking at and what we're exploring together. So that starts at the very beginning and continues throughout the process of the assessment piece. I think it's really, really important, as Tara just mentioned, to conduct the assessment with the assumption that at least one parent is autistic. You may know that about a person, but you may not know that about them, and they may not know that about themselves yet. So if we work from that assumption that at least one parent is autistic, then we will provide universal accommodations that benefit everybody. So it's really important that we do that. It's also really important that we prepare children for the process, whether they are a 2-year-old or whether they're a 17-year-old, but that we're preparing them for the process and what's going to happen. Bearing in mind, as Tara just spoke so beautifully about, that we are bringing people into an environment that's new, that's different, that's unfamiliar, that potentially they feel unsafe about. So it's very important that we prepare them for that and give them information that they can process in advance around what will happen, what the space will be like, and that they have some control and some agency around how that happens. We need to involve older children in the process, you know, in relation to how we're making sense of things. Does this make sense to them? Particularly adolescents, they need to be part of that conversation. This is about them, and, you know, they need to be involved in understanding what we're talking about and what does that make sense to them and how they know themselves. And then we also need to start thinking about the assessment, including the report, as a therapeutic process. We call it an assessment, but really what it is it's an exploration of identity with a person or with their family. And that's a therapeutic process, because while a child or a young person does not change, as you know, as the process continues, they're still the same person, but how they know themselves and how the people around them know them is the part that changes. So there's quite a therapeutic aspect to that. And then it's so important that children and parents feel comfortable, happy, and listened to throughout the entire process.
Yeah, and just to add, I mean, you already said it anyway, but the aspect of providing information about the neurodiversity affirmative framing from the very start, what we mean by that is it's not that the child and parents come in and you do a very standard autism assessment, concerns, deficit, and then in the feedback are suddenly saying, oh, well, actually, we're going to frame it this way. You know, more and more parents are coming in actually with you know, these kind of ideas around autism and this framing, which is wonderful to see. But of course, there's lots of parents who are still who have heard a lot of ableist information about autism and disability and are coming in saying ASD and concerns and all of these kind of things and looking at it in a very deficit-based way. So what we're saying is from the very start, you're having conversation, you're opening that up in a respectful, kind way. Of course, you're not shaming any parents saying, oh, we don't use that language anymore. Of course not. But, you know, there's little chinks where you go, oh, do you know what's actually very interesting? The autistic community think this about that particular word. Or I read this book where you know, an autistic advocate said this, maybe you'd like to read it. So you're giving them the information, and you're guiding them towards the right resources, the neuroaffirmative resources and language, in a gentle way through the process, so that it's not suddenly in the feedback coming to, well, this is how we're going to frame it. Yeah. So again, this is, I mean, reasons given for non-referral of a diagnosis of autism. And really what I'd like to just highlight really briefly with this, it's not just about non-referral, it's also about diagnosis not being given, or autism not being identified because of all of these different things. And when you see that happening, what you're seeing is the professionals not really understanding autism or autistic identity or any of those things. So for example, you know, of course you can be autistic and have a really good sense of humor. Of course you can be empathic. Of course you can be clever. Of course, all of these different things. It's just really, really being aware as a clinician of the stereotypes around autism, and being sure that that you're not falling into them in the assessment process.
So in thinking about the diagnostic criteria around autism, and the two main criteria, the DSM-5 and the ICD-10, it's just to talk a little bit about what's unhelpful about those and what is helpful. And I guess in thinking about particularly what's unhelpful about them, both sets of criteria are quite deficit focused in their language. And in their descriptors around autism. So they both mention things like abnormalities, they talk about disorder, they talk about delay, and they seek for professionals to observe those things within people. And that isn't really helpful in thinking about things from a neuroaffirmative perspective. It's not helpful at all. It's very much out of step with current understanding in relation to autism. And what it's doing is it's holding neurotypical people as a sort of a gold standard for how humans should be, and comparing other people to that standard, which is completely wrong. The other issue with the diagnostic criteria as they stand currently is that both the DSM-5 and the ICD-10 fail to recognise many aspects of autistic experience. Many parts of being autistic are not recognised within the criteria. Things like autistic communication, particular personality characteristics, things like executive functioning experiences, people's experiences of empathy, people's abilities relating to hyperfocus, sense of social justice, people's expertise and depth of knowledge, creativity. There's huge aspects of being autistic that aren't recognised within the current criteria. So those are, I think, two of the main areas that are unhelpful. There are aspects of the criteria that are helpful. I think if you take away the deficit-based language, the areas that the main areas that the criteria talk about are actually reasonably okay in terms of recognizing autistic experiences. Obviously, it does leave out many aspects of being autistic, but on the whole, they are useful in terms of the areas. It's just how we think about those areas that we need to reframe. So not from a deficit perspective, but more from exploring what are people's preferences within those areas and what are their experiences. And I think central to all of that is really reflecting on how would you feel if you were an autistic person, or you were somebody with an autistic child and you were reading those criteria. And they were written about you and your experiences. And we really need to think about that and reflect on that.
Yeah, I mean, I think the more that you work within a neurodiversity affirmative framework, and the more autistic people that you know and are in your community and are your friends, to go back, it's like every time you go back, I wouldn't even put up the DSM-5 criteria here, because it's like it's so awful to even look at when you read it. And also I should say that you know, we're talking today about child autism assessments. So in actual fact, the DSM-5 criteria is what we use across the services of the people who are, Childversity, the Children's Clinic, the Adult Autism Practice. Actually, at the core of our assessments, we are using the DSM-5 criteria. That's what we're bringing it back to. But like Maeve said, we're not looking at deficits. We're not looking at any of those things. We're not looking at how people fail, but we're looking at the areas that the DSM-5 have highlighted. And actually, typically, when you do a really good assessment, you can map that onto the DSM-5. And actually, it will generally, quite accurately, in my clinical experience, map onto it. Yeah.
So in thinking about tests, sorry, Davy, did you want to start there?
No, go for it, Maeve.
Yeah. So I guess we need to be really aware that all the standardized recognized tests that we use currently are exactly what we've just been talking about. They're measures of how much a child is failing at being a neurotypical person. And we really need to be aware of that. If we're using them, that's what we're looking at. So if we're using them, it's very necessary that we constantly adapt the language in all the tests when we're presenting those things to parents and in reports. And those of you who use things like the ADIR will really know that. And just even looking at the very first question in the ADIR, it starts with what are a parent's current concerns, and it then continues with what was the onset of symptoms, and even the language around that. If you're to say, going back to Davita's point there earlier about if we do all of our sessions in those ways and then come in for the final piece with the neuroaffirmative framework, it doesn't make sense. So talking about autism from the perspective of concerns or symptoms or abnormalities is not neuroaffirmative. So we need to be aware of that when we're using tools such as the ADIR. And again, the actual information that you're gathering with the ADIR is helpful in terms of the areas, but it's how we present that to people and how we ask those questions that we really need to reflect on. Do you want to add anything there, Davida?
Yeah, exactly. I completely agree. It's just about adapting every question. And even in terms of, if you're talking about current concerns, I mean, often, a lot of the time, particularly when parents are neurodivergent or autistic, they won't have concerns. So they're like, no, I don't have any concerns, but their child is autistic and shares a lot of autistic experience with autistic people. But if you're saying, what are the concerns? It's not actually going to capture what you want it to capture. So again, it's just about adapting the language all the time, both when you're presenting the information to the parents and in the reports. And it's the same for the ADOS as well. And the thing about the ADOS is the ADOS can be very helpful. I mean, myself and Maeve, we talk about this a lot. We're still using the ADOS. So we still use the ADOS and the ADIR. Sorry, the ADOS for younger children, not for older children. But for us, we kind of feel like that the ADOS is helpful for younger children, but becomes less helpful the older a child gets and the more a child can communicate and express for themselves about their internal experience. And it's really, really, really common in my experience for teenagers, particularly those with low support needs at times, to not meet the criteria at all on the ADOS. And in fact, I've seen children, it's rare enough, but I've seen children not meet the criteria on the ADOS and the ADIR and still be autistic. Now that's rare. Typically, I find that they will meet on one or the ADIR in particular. But it's just to really think critically about what we are looking for in those tests, even though we need to do them. I mean, we're still doing them because they're the best of what we have, but it's just about really thinking critically about what we're assessing for. So here's an example. So if what we're saying is that the ADOS isn't particularly helpful for older teenagers, because what the ADOS is doing is assessing for only observations. It's nothing, you ask a few of the questions, how do you feel, what makes you angry, what makes you sad, but a lot of it is observational. So if a child has learned to mask and present in neurotypical ways, they're not going to show any of those things. So here's an example of, now this is obviously for an older teenager who has very good verbal skills, but here's some examples of reframing some of those questions, looking at internal experiences, but still mapping all this information then we mapped onto the DSM-5. So we provide all the stuff that we're talking about here. We're going through it really quickly. We're going to provide in a resource pack to everyone attending, so don't worry about any of that. So for example, you know, friendships. Are these things you'd like to have? Give a bit of information here about the friendships in your life. Have you found difficult? Have you made friends with people who you feel are like you? Do you feel you have to pretend to be a certain way with your friends? Has there been any big events in your life which you feel were significant? If this one, for example, looking at body movements, is there anything you do with your hands or body that helps you to feel calm? Or if you're happy, excited, for example, flapping your hands, etc. Describe how you feel when your plans change. So you can see there, you're not sitting down, because the typical interview schedules and checklists, what you're doing is if you sit down with a child or parents and you have a checklist in an interview that's framed negatively, you are essentially through that assessment process telling that child and parents there's something wrong here. There's something just by giving the questions in a deficit based, do you have problems with friendship? Do you have problems with this? Essentially, you're asking them. And then at the end of the process, you're like, yes, you are autistic. What you're saying is, yeah, you have all those problems. They're all problems. So you just have to be really, really, really careful. And it's possible to do. You're just taking away the judgment. You're taking away the deficit. And you're asking the person, tell me about what you like doing. Tell me about your hobbies. Tell me about your passions. Do you like focusing on them for ages? You know, what are your organization, you know, instead of, do you have terrible organization and planning skills? How would you describe your organizational planning skills? You know, do you have issues in school? No, give me some experiences. What do you like? What do you don't like? What do you find difficult? What's good? So it's about asking all those same questions, or even this one. So have you read books, seen TV programs? Have you watched videos about autistic people that you relate to? And we'd often, depending on where the child is in the journey, you know, halfway through the assessment, we might say, go off and watch that video, you know, the Rosie King video, or read that book, or, you know, and see, do you identify with that? What do you think about that? And for parents of children who wouldn't be able, you know, younger children or with higher support needs, you could say to the parents in the middle of the assessment as well. So yeah.
Yeah, this is just another way of asking very similar information that David's just talked about there. So, you know, and I guess for us, when we're doing this with younger people, we are sometimes, you know, asking them about this, and then sometimes they will write about this. So it's about giving them that choice around how would they like to share the information with you. Going back to Tara's point earlier about giving those choices around communication methods. And, you know, for a lot of young people, it is utterly astounding how expressive they can be when they write about their experiences, when you ask questions like this, how articulate, how expressive, how insightful they are. It's amazing, and the richness of the information that you get that you never get when you do an ADOS in the way that the ADOS is laid out currently for older people, or, you know, for teenagers. I think that the richness of the information you get by doing it this way is far more valuable and insightful and helpful in exploring somebody's experiences with them. So this is just examples of another way of asking about the same information. So I think we'll move on, if that's okay. So I guess in saying all of that, and we were reflecting on this together all the time, but particularly recently, it increasingly feels to us as though, you know, when we're trying to think about how to engage in a neuroaffirmative autism assessment, when we're using the tools that we currently have available to us, it feels like we're trying to fit a structure or a different approach onto the tools that we already have. We're having to adapt them, and we're having to think about them differently, and they become, you know, not unhelpful. They're still useful, and we're certainly not saying that, but they become, you know, you start to wonder about whether there's a better way. And I guess the purpose of this slide is around thinking about opening up that conversation around, if we're truly going to engage in a neuroaffirmative assessment process for autism, which is what we should be doing, do we need to start thinking about moving away from our traditional structures, our traditional assessment tools, our criteria in the current formats that they're in, and what should an autism assessment look like? So some of the things that we thought about that would be important to this are things like, is this child communicating in autistic ways? Are we looking out for autistic communication? Do we know what that is, and what does that look like, and how would we recognize it? Does this child have autistic interests or patterns? And looking for experiences that align with autistic experiences rather than deficits or deficiencies as per the other tools that we're using. Is their sensory perception aligned with autistic experiences? Do they move their body like other autistic people? So essentially, does their current experience align with autistic experiences? Not, are they failing as a neurotypical person? And we really, really need new assessment tools that reflect this. There's very, very little out there. There's nothing that's standardized or that's that's been reliably researched that is there that we can use, apart from our own experiences and clinical judgment in relation to our understanding of autism. So we really, really need structures and systems and tools that reflect what an autism assessment should look like, rather than what we're trying to do now, which is adapt our current tools.
Yeah, so again, we've already started talking about the feedback session, or the session where the autism is identified. So again, it should feel like a continuation. So again, it's not a big surprise during this session that autism is identified. You're really avoiding the tragedy narrative. So you know, I hear this all the time. I'm continually surprised that I continue to hear this, people saying to me, I went for an autism assessment and it was presented like a tragedy. I'm really sorry to tell you it's autism. Your child is, your child has autism, to use the outdated language. So, that should never happen. Of course, you're sitting with parents' feelings, you're supporting them through the process. There is going to be a lot of, not always, but some parents can have grown up in a world with a lot of ableism and a lot of negative attitudes towards disability, and find the process difficult. So of course you're supporting that, and of course you're not coming in only talking about strengths, because that's not going to support that parent who might not need it in that particular time. But you are certainly avoiding the tragedy narrative. You're involving the teenagers in a very supportive way. You are, and actually there's lovely stuff about this in webinar 2 and in webinar 3, actually, around involving teenagers, involving children in the whole assessment process and in the feedback process as well. So I definitely listen back to those as well, because a lot of this is covered. Again, just being aware that for autistic parents, a 1.5 hour feedback session is a really long time. So just to really be aware of this and provide accommodations, and again, making sure the parents and children are happy and listened to throughout. So again, I think I already covered this. What we get asked a lot of the time, a lot of the questions that I get asked about the neuroaffirmative process is, how do I balance the neuroaffirmative framework with parents being really upset, and how do I balance that? How do I balance that in that session? And I think the real answer to that is what we were talking about it being a process. So from the very, very, very start, if you're supporting them through that process and you're providing them with good information, and there's power sharing, and there's a collaborative process, and they feel that you're with them, you're on their side, you're listening to them, you've seen their child, you understand where they're coming from, and you're also saying this, that a lot of those things will go very smoothly because of it. But it does take a lot of skill and I suppose support from the very start.
So in terms of report recommendations, Tara, did you want to speak about this?
Yeah, we were discussing there that report recommendations within the neurodiversity affirmative framework would be looking at co-creating goals first off, and that's again continuing to follow through with this collaborative process that we were discussing. So with older children, you can co-create goals that they would like to achieve. With younger children, you're talking to parents to find out, what does the child love? What would they like to do? Do they love, for instance, just simply like a musical instrument and they'd like to play that more, but they can't be in the environment because of, for whatever reason. So just figuring out, listening, and being able to use those in the report recommendations. Fostering a positive autistic identity. And now that's like 4 words, but really there's weeks and weeks and weeks worth of training in how to do that. We have another slide briefly on that. We go into depth with it in other trainings in our book. But it is so crucial because of everything that you've heard so far about all the negative messages and the ableist society that we're all brought up in. All the negative messages that are out there about failing at being a neurotypical. Fostering, a positive identity is going to have such an impact on the child's mental health moving forward in their life. Connecting them with the autistic community. For school and for home and for any other area that the child is in the report recommendations, doing an environmental audit, because the outdated approach was that we need to desensitize children and young people to be able to put up with sensory environments that are really distressing. But we now know that that's really harmful. And instead, what we need to do is environmental audits so that the child or young person can be safe. They can have sensory safety wherever they are. Looking at things from a strengths-based approach, so uncovering the child's unique strengths and helping them uncover what they are and use them more. Promoting interoception. A very large number of neurodivergent people have difficulty with what we know as interoception, and that is being aware of body signals, being aware of from hunger, body signals such as hunger, thirst, urges to go to the bathroom, which also is linked in with being aware of emotions. So when we talk about children understanding how others are feeling, a lot of our children don't understand how they feel themselves, and they need help with and support with that. So it's a really good recommendation for OT support there as well. And then self-advocacy, becoming aware of what they need, and autonomy, understanding that they are whole and perfect as they are, and helping to provide and support that rather than assuming incompetence in all those working in around them. Then we have a list of what not to recommend, and that is no goals that are normative or curative, and that means no goals that are trying to make the child appear like a neurotypical child or so-called fix or cure their neurotype. No neurotypical only social skills programs. So there will become a point potentially where it would be really beneficial, if they wanted it, to do some kind of peer support around being with other autistic children, being with neurotypical children, everyone learning about each other's communication styles and preferences, just the way you would teach different children about different cultures. No pathology-based language in your report, and no compliance-based behavioural recommendations. And then this is where I mentioned about cultivating a positive autistic identity. There's a lot there, just about recognizing and increasing their strengths, providing opportunities for flow states. Autistic people have very strong interests that can really pull them into a wonderful flow state. So providing opportunities for that, we know from the field of positive psychology how much it impacts well-being to be able to experience that, appreciating their own developmental trajectory, valuing their internal drives to move their bodies, communication preferences, their own play preferences, rather than teaching them how to play. They have their own way of playing, their own learning preferences. Again, autonomy, self-advocacy, connecting with their peers, appreciating and understanding the social model of disability, where they recognize the failure is not within them, but in society that we live in right now. And developing a personal perspective from whatever age you can do that, of the components of a good life, rather than assuming that a neurotypical version of a good life should be the same as what a neurodivergent person would want.
Yes, so this is a tweet from Mary Dougherty, who is a consultant anaesthetist and founder of Autistic Doctors International and a phenomenal autistic advocate. So she's actually was tweeting about this webinar series and this webinar that was on tonight, talking about next week, looking at neurodiversity affirmative reports. And she said, imagine if your or your child's autism diagnostic report was where you turn to on a dark day, needing affirmation, comfort, and hope instead of throwing it in a drawer and never wanting to see it again. So it really made even me think, because, you know, this is all a process. And I mean, I should say that my reports aren't perfect and our reports aren't perfect. And I, you know, even putting together this webinar today, I was looking at reports that I thought I'd share and seeing aspects that since then I would reframe and I would say differently and all those kind of things. And I was looking at them and going, God, would my reports, I mean, yes, they're neuroaffirmative, but would they provide comfort? I'm not sure that they even would. So it really made me think, you know, I think that we go into, you know, so many professionals, we go into this work because we want to help people and we want to support people and we want to improve people's lives. And yet then we kind of get into this system of doing assessments and doing these reports that are damaging and upsetting to parents. I mean, we heard a parent advocate earlier on in the webinar series who said she doesn't even look at those reports. And I hear that constantly, time and time again, that it's so, you know, hurtful to even look at them. And you think, well, why are we doing it that way? You know, we think, oh, we need to do it this way in order to maybe access resources, but it's not true, which we'll be talking about in a minute. So it's just really, really about going back to basics and thinking, just because we've been doing reports this way for such a long time doesn't mean that we need to continue doing them that way at all. And really remembering that, you know, that the child might be reading the report and the parents are certainly going to be reading the report, and what is its purpose, you know?
So just to go through what a neuroaffirmative report with all of that in mind, what Davida just mentioned there, and particularly in terms of thinking about comfort and hope, I think, what should they be? What should they look like? So definitely strengths-based, appropriate language used throughout. They should be part of the therapeutic process for both children and parents. They should be helpful in explaining and validating people's experiences and how they experience the world. We should be providing reports to our children and young people directly in language that they can understand, and in explaining what their identity is and how we understand that in an affirmative way. And we'll show examples of that now in a moment as well. There should be an emphasis on aligning with autistic experience instead of failing at being neurotypical. So exactly what we've just been talking about there. How do people's experiences align with autistic experiences, not deficits and deficiencies in relation to being neurotypical? We should not be reporting scores. They're not meaningful to people. They don't always understand what they mean. They're also a complete snapshot. So I think moving away from that and moving more towards, you know, a therapeutic understanding of people's experiences is more helpful. We still need to include how a person or young person met the criteria in the DSM-5, the ICD-10, whatever it is that you're using. We need to demonstrate and show that, and we'll show examples of that in a moment. We need to highlight autistic strengths, the things we were talking about earlier. We need to show the areas of need and how to help. We still need to include that. We're just not using it or showing it from a deficit perspective. That's disrespectful to the autistic experience. So we need to demonstrate what the areas of need are that a person has, what they need support with, what they need help with, from an affirmative perspective. We need to reflect on a child reading their own report when they're older and be aware of that, and also reflect on what it would be like to be the parent of a child whose report it is. And we've heard, as Davida said, from a parent about how they felt about their report or their child's report. And reports need to be easy to read, they need to avoid jargon, and they don't need to be significantly lengthy. They need to be easy to digest and to process for both children and their parents.
Yeah. And I really think that we really just need to keep in mind, who are we writing this report for? Because I think a lot of the time, you know, we're writing it for other professionals, and really we need to move right away from that. But while, like Maeve said, we still do need to show that we've done a best practice assessment. Of course, we need to show that it's an in-depth assessment and we've used this tool and, you know, we've reflected on this. So it's not that those things aren't included, but beyond that, you know, you're writing that report for the child and for the parents. It's not for further professionals to see, you know, you know that you've done all these things. So I'm just, it's 9 o'clock now. We're reaching the end. We're going to go through some sample, a few sample reports. So we won't go too further, but I see there's not a huge amount of questions in anyway. So if anybody wants to put in their questions now, we'll go through some sample reports. I know we said we'd start the Q&A at 9, but we might start it at maybe 5:10 past, probably 5 past, while I go through these. So these are just some examples. And again, like I said before, we were even looking through these and I was seeing things that I would change and I would word differently. So I'm not saying this is the ideal, but we're just showing this is an example of a report for a teenager that could be done in a neuroaffirmative way rather than a traditional way. So as you can see, the assessment procedure looks very similar to any of the previous reports. You're saying that you did the ADIOR. In this particular one, you're doing a structured clinical interview based on the DSM-5 criteria, informed by the ADOS. If it was the younger child and you did the ADOS, you could put there in the assessment procedure that you've done the ADOS. So obviously then there's background information, previous assessments. I keep those really brief. And again, really strengths-based as well in those areas. So again, so traditionally then, if you have the psychological assessment, usually what you see is test. So usually what you see is, here's the results, here's the ADIOR. And I was doing it I was doing it this way up till 6 months, or how many months ago? 3, you know, this is not that there, you know, this is a very new kind of way of doing it. But traditionally what I would have done and what most people do is you have the ADIOR, and this is what the ADIOR is, and these are the scores of the ADIOR, and this is where they met the criteria in the ADIOR. Then you have the ADOS, this is the ADOS, and this is where they met the criteria in the ADOS. And then you have your summary, met the criteria in the ADIOR, met the criteria in the ADOS, you know, meets the criteria for autism. So what we're doing is we're pulling right back from that. We're still doing the ADOS and maybe doing the ADOS, definitely doing the ADIOR. But what we're doing is we're gathering all the information together from the ADOS, from the ADIOR, from the teacher, from the parents, from the clinical interviews, all those different things. And what we're doing is we're just mapping all that information together onto the areas of the DSM-5. So a really brief here, you'll see at the top, assessment met the criteria for autism on the ADIOR, the information was gathered, and then you're just taking the information that you have gathered through all these different areas and you're putting it into developmental history. So you'll see Mary's parents reported she reached all of the areas. And here, for example, then here's another area of the DSM-5, all this information came from different areas. It came from the interviews, it came from the ADIOR, it came from the teacher. And you'll see here that it's not done in a deficit, the language isn't deficit based. In the first note there, instead of Mary has, it's been so long since I've done it, but like deficits in social, emotional reciprocity, you know, unable to engage in chit chat. Instead of that, you're just saying, Mary reports that she finds engaging in small talk okay. She doesn't like it outside the home. She's happy to talk with others about topics of interest. She likes this. She doesn't like this. This is what we're, so if it's actually getting back to just a factual description, factual and respectful descriptions of the different areas. So, you know, Mary's mother describes that she occasionally finds jokes difficult to understand. She has one close friend who shares similar interest. So do you want to go on to the next one, Maeve? So use of non-verbal communication. Instead of deficits in eye contact, Mary describes how she finds making eye contact with others uncomfortable. You know, Mary's mother reports that, you know, go on. So these are the various areas. So like experience, so again, in experience, so these are all areas from the DSM-5. You're just really factually putting in You know, Mary's mother described how she wasn't hugely interested in children, hesitant about playing, all those kind of things. And then again, so instead of here, what it's here is looking at, oh, I don't even, what is the language of the DSM-5? Restricted and repetitive. So instead, you're not using the words restricted. Instead of saying restricted and repetitive, I can't even remember what it is now. But you're just calling it interests and behaviors associated with the autistic experience, and you're just calling it body movements. Mary explained she liked to arrange her beanie boos in a particular way. She noted she finds it calming. She used to when she was younger. Mary described how she has a particular way of tapping her leg. She likes it. So again, it's all the information is there. It's just not done in a it's just not put in a deficit way. And again, preference for sameness. She has excellent attention to detail. She notices small mistakes. She just likes going to unfamiliar places. She has passion. So see here the respectful way the passions are spoken about here. Instead of, you know, what is it? Again, I can't even remember now what it says in the DSM-5 about, like, not obsessional interests, but anyway, it's about, what is it, Maeve?
I can't
so funny. It's so far, it's so bad. Anyway, but you know, so instead of like focused interests or whatever the language is,
repetitive, restricted
interest, narrow interest.
Thank you, that like interferes. You're saying she has a passion for the TV show. She loves talking about it. She has loads of merchandise. She, you know, so it's all the same information. She has in-depth knowledge that she likes to talk about, you know, so it's all there. Yeah, you can move on. And then you're talking about a profile of strengths and needs. Again, this is one way of doing it. It doesn't have to be like this. So again, you're focusing on the strengths. She's very kind. She's very gentle. She's a variety of interest. She's great at detailed information. She's intelligent, great determination. You know, the following needs emerged as priority. You know, that her family, her teachers, her university, they would benefit from learning about the autistic experience in neuroaffirmative ways and adapting their expectations and communication styles to suit Mary. So again, you're working on advocacy within the community. It's not all about Mary changing. Mary would benefit from furthering her understanding of the autistic experience, how it relates to herself. She'd benefit from an occupational therapist to develop her understanding of her individual sensory profile. And Mary, you know, needs support with her mental health experiences. So you can see it's not taking a Pollyanna, we're only looking at strengths approaches. Of course, you're giving her support in the areas she needs.
Yeah.
And then, yeah, do you want to take that, Maeve? Yeah.
Yeah, so I suppose just in terms of how do we summarize it then, all of that information that we've gathered, and this is just one example of an affirmative way of doing that, and you know, talking about her strengths, talking about what you know her experiences are, and giving a little bit of background around that, and then concluding, I guess, that, you know, in collaboration with Mary, with her parents, you know, that this was a piece that we all did together. And this is the sentence that's needed to be in reports to access other services and that educational supports and things. We do have to state that she fulfills the DSM-5 criteria, and that is the criteria that we're benchmarking against, as Davita's just explained. So it's valid and it's appropriate to put that in. But we're talking about, you know, also the more important piece, that overall her experiences of the world align with the experience of autistic individuals. That's the fundamental piece that we're looking at and talking about.
Yeah. And can I just add as well, I know that a lot of the examples that we showed there and this example of this report are obviously children with you know, they're in terms of their communication skills, they'd be quite low support needs. But of course, all of this applies to children with high support needs, to children with added intellectual disability. It's all the same concepts, even though the ones that we're talking about here. So in a way, I feel bad because I know that in earlier webinars we said, look, this isn't all about, you know, the children with low support needs. It's all the same. But it's all the same concepts, even though that example was a teenager who was going to go on to university. And this is a gorgeous report. So again, this is just an example, and then we're going to finish up and go to Q&A. This is a gorgeous report to give to the child that was done by Niamh Malamphy, who's a psychologist in the children's clinic. And this is a really good example of this. So there's the front page. You know, you came to see us in the children's clinic. This is your very own report from a psychologist. What does a psychologist do? We listen to you, we talk to you. Yeah, you can go on. Things you told me about yourself, what you like doing, what's something you found hard. Yeah, activities we did together. So the whisk was obviously done here as well. And then we also met for a play session. And then at the bottom there, it says, from all our talking and spending time with you and also with the people who you care about. This is so funny. Sorry, I actually can't see it because, oh yeah, we've learned that you are autistic. So you can see here the power sharing. We have learned, it's not I identified that you were autistic. We have learned that you're autistic. And being autistic means you see the world in a different way. Being autistic is not a bad thing. It's actually a really important and wonderful thing. So many other boys and girls who are autistic. Being autistic means that you'll need support in some areas to ensure you can feel happy and comfortable. Autism is all about part of the way you communicate, interact, experience your senses, spend your interests. Yeah, again, we'll provide all these. All these things are perfectly okay. You are amazing, kind, gentle, and fun. I think you're a great daughter, sister, and friend. Every autistic person is different, just like each and every human is different. And all of those wonderful things. So you can see there, that's a really nice example. And I should, around a report. Oh yeah, sorry, I think there's one more page. Actually. Yeah. So learning about autism is going to be really helpful for you as you continue to grow older. I'm going to share lots of books and websites with your parents. Your family can celebrate autism, learn lots about it. So that's a really lovely example of something that could be given to children and also adapted both up and down for children with more or less written skills. Yeah. Okay.
Yeah.
Do you want to stop sharing there, Maeve? So we, oh yeah. Yep.
Thank you so much, guys. I think that was an absolutely amazing presentation. I've been writing furiously because I know I've learned a lot, and I've no doubt that everybody tuning in at home has as well. So thank you so much for sharing your knowledge so generously with us all this evening. We had a late rally of questions, so we have a good few to get through. Some I might put specifically to individuals if I think they're best placed to answer them, and some I might just open up generally and people can choose to come in whenever it is most suitable. Where I just want to start is somewhere quite specific. We had a question early on in the session, querying the term asynchronous communication and asking for an explanation around what that term meant. I don't know if Tara might like to take that one.
Yes, thanks, Adam. So synchronous communication is live communication where it's happening in the moment, like we're all here tonight, right now. Asynchronous communication is where it's not happening live. So it may be, for example, that you could say record a video message for somebody and send it to them by email, and they have time, or a text message or an email, some written information, and they have time to consider that communication, consider the questions, and then in their own time, when they've had a chance to process it, they will write the answer or perhaps record an answer, either with video or audio, whatever communication method is most comfortable for them. And then they...
Thank you so much. Does anyone else have anything they want to add to that? I think that covers it quite clearly. Another question, and this is quite a meaty one. And I suppose what someone would like to understand is there a tension between promoting positive autistic identity and then promoting functional skills, particularly maybe with young people who might have higher support needs or perhaps co-occurring intellectual disabilities? Does anybody want to take that? The example the person is citing is that, for example, promoting functional play skills is useful for promoting functional language skills.
I might just start. Will I start? Sorry, there's two different things there that I just wanted to figure out. So I think there isn't a difficulty with promoting a positive autistic identity and teaching functional skills. It's like what we talked about in the first webinar. It's kind of one of the myths about the neurodiversity movement that it's only for people with low support needs. The neurodiversity movement and being neurodiversity affirmative absolutely embraces all kinds of difficulty, all kinds of levels of disability. And so it is absolutely part, I mean, it is part of it to teach children functional skills. Absolutely 100%. But where I'm a little bit confused there, but then there's another thing of functional play skills. So I think that's the difference. So functional skills, yes, absolutely. Children need to learn to, you know, develop skills. It's not that we're saying we're not going to teach them anything, but what you need to be careful of is the play skills. So is it autistic play or is it neurotypical play? So for example, what would have happened in the past is that, or continues to happen today, but that there would be an emphasis on, we're going to teach autistic children to play in neurotypical ways. So we're going to get them to sit down and play with the teapot and say, can I have a cup of tea? Oh, can you have a cup of tea? But now plenty of autistic children love that kind of play. I'm not going to overly generalize about that at all. But being truly neurodiversity affirmative is not saying, I'm going to teach you to play the way I think you should play. It's about join, and you can still develop language skills, because I know that a lot of what they're probably coming at is that language does develop through play, absolutely 100%. But what I would say is, it's not about getting children to play in neurotypical ways. It's about joining them and respecting their autistic play. So you can get on the ground and you can line up the teapots and you can develop language around that if you want to. You know, so yeah, I don't know, did I answer that really properly? Does anyone else want to join in there?
Yeah, I love what you explained there, how you explained it. And I think as well, that ties into the developmental trajectory and what we're seeing, the autistic developmental trajectory as being different. That we quite frequently will see, like, a young child is very focused in on one area of their experience for a while, and they'll be developing that, and it may be, say, motor skills and not no speech. And then, or it may be a lot of speech, but not learning how to move their bodies or crawl or walk. So the developmental trajectories can be different. There are artistic ways of being. And what we're seeing is that children do learn to develop in their own way if allowed to do it, rather than being halted, that process being halted and then being rediverted into, no, you have to learn to play this way.
Yeah.
Maeve, what do you?
I think just to add to that, I have done much to add, but I think it depends on the reason for, you know, why you're teaching particular things. I think it comes back to that. You know, I think it's perfectly acceptable and important that we teach people skills as we would with any child. But if the goal of that is to teach people not to be autistic, then that's not okay. But if the goal is around skills development and functional skills, around teaching safety, around teaching communication, you know, I think that's okay, as long as we're working within autistic experiences of those things. You know, so I think it comes back to why, you know, what the goal is of what we're trying to do.
If I can just jump in there, sorry, just a thought, but like functional skills as well, I suppose you have to think, who are they functional for? Are they functional for society? Are they functional for the family, or are they functional for the child? So I think it needs to be, yeah.
Mm-hmm. Yeah.
Another question, and it is quite, I think, closely linked to this question, but perhaps, you know, when we approach it this way, people will have more thoughts or comments they want to add. You know, somebody saying that what they're trying to do is understand this way of thinking in the context of a young person who might also have a co-occurring intellectual disability, and they just think it's useful to understand that, given the high rate of co-occurrence of those two diagnoses and experiences. So I don't know if anyone has additional comments they'd like to add to that.
Yeah, I mean, I think it's going, again, you know, it's going back to my earlier point of that it's not, being neurodiversity affirmative isn't saying everything is, we're only going to focus on strengths. It's not actually saying we're only going to focus on strengths and that everything is wonderful and that, you know, that child doesn't need to learn any skills. It's not about that at all. It's just reframing how we look at disability. So it's embracing all the people who have more significant disability, and it's helping them with what they need, but now I've lost my words now this webinar, but the two aren't mutually exclusive.
No, that's clear.
Yeah, the two aren't mutually exclusive. Yeah, sorry, Maeve, did you want to?
No, and Tara, I think you want to come in there.
Yeah, just to say, I suppose I have a small caution that if anyone's here tonight watching this webinar thinking they're going to get the complete picture from this 1 hour training, you're really not. This is building upon 3 previous weeks of really in-depth work around the social model of disability, ableism, you know, disabled people's voices and human rights for neurodivergent people. So it's all built upon that. And if you just come in here now tonight without any of that grounding, I think it would be quite difficult and maybe a bit disorientating to listen to us talk and try and figure out how you put all this together.
Yeah, and there would be, I mean, there's been a lot of advocacy from people with quite significant intellectual disability, and what they're saying is this is how they want to be, that this is how they want to be spoken about, this is how they want disability to be framed. So it's coming from them as well. It's nobody talking for them as well. But yes, I agree with you, Tara.
Yeah, and everything here as well is around your universal design. So it's to benefit all of humanity. That's the idea behind it.
The next question, and I actually have something I can chip in here if other people don't. There's a very good question around support or resources for parents of children who aren't English speaking and who are navigating the diagnostic process. Has anyone had any experience of that, or is there any resources that you can signpost to?
Do you know, Adam? I actually can't think of any.
So just we recently published a guide called Starting the Autism Journey for people going through the diagnostic process. It was in partnership with St. John of God's, and I think Jess was good enough to review the document for us. Actually, we have a second resource guide due out in the next few weeks, and that's looking at kind of your post-diagnosis period, and we're talking about children here. But one of the things we have actually discussed is a lot of queries that come into As I Am are from families who English isn't their first language. So what we're saying very openly is if anyone would like to translate the document into another language or could help us do that, we'd be very, very open to it, because I think it is an additional barrier that it would be great to help people with.
Yeah, that's great to know, actually, Adam, because we do sometimes individually have families where we might just access a translator and get that one piece, but that would be great. Yeah, okay. Yeah.
There is the Informing Families website. I actually don't know how affirmative it is, but they do have information there about autism in different languages. I think it's informingfamilies.ie, but again, I would be really cautious about the content. I can't speak for the content there, but there is, you know, maybe that's another project where that content could be looked at in terms of it being neuroaffirmative, but the language piece is there.
Starting the autism journey is
that's
amazing.
Another really good tip. Oh, good stuff. The next question I think is a really good one. I thought it was really interesting just having heard this discussion, and I think a lot of people at the webinar will be aware of how things that happen in the health system and the education system don't always talk to each other. And what one person is wondering is there a familiarity with this approach and this way of thinking amongst CNOs? And I think that's a good question. I don't know maybe if Davida or Maeve have any experience engaging with CNOs with this kind of report.
Yes, absolutely. This came up actually in the webinar the second night with the Carlo team, who engaged with their local CNO in relation to neuroaffirmative reports. So the HSC Carlo team are working in a neuroaffirmative way, and it might be helpful for that person if they want to go back and actually review that webinar, the recording, and the feedback from the CNO in that area there was absolutely that the neuroaffirmative report style, there's absolutely no issue whatsoever with accessing what children need in terms of supports at school. There are particular things that they look for which are very much part of the neuroaffirmative style, which is looking for, you know, things like confirming DSM criteria are met and things like that, and outlining what a person's needs are, and that's very much in keeping with a neuroaffirmative approach.
Yeah, I agree. There shouldn't be any issue. And if there is an issue, as we were saying in that webinar, just pick up the phone to the CNO, but there should be no issue.
That's I think really helpful for people to know. There's another two questions here, and I think they're quite linked, but I'll take them in two parts just in case there's any nuance. You know, one person, it wants to know that if you're a clinician who very much has this broader understanding of autism, but perhaps in the service that you're working within, you're very bound by DSM-5 criteria, what advice or guidance would you give to a clinician in that scenario?
Well, I mean, what I would say specific, I mean, we still use the DSM-5 criteria. So you can still do it with the, you know, it's just you kind of like hold your nose and ignore the deficit-based language and use, you know, what we've done is we put the DSM-5 criteria into a new document of our own that doesn't use that deficit-based language, so we don't have to look at it. But you're still using the DSM-5 criteria, but I know that's very common. I mean, I know this is all very new stuff, and most services aren't doing this. Of course they're not. But it's about making small changes and maybe, you know, talking to the service that you're with and making change within that service. But they're not, again, they're not mutually exclusive. You can still use the DSM-5. You're still talking about needs, you're still meeting criteria. But yeah, that is something that's coming up. Yeah.
Can I oh, sorry. Can I make a unrelated suggestion there that you just said about just about general trying to adapt to a neuroaffirmative approach, but that about holding your nose when doing the DSM-5 criteria. I'm guessing a lot of people also read a lot of research, and it really helps, like when you're reading research that's really deficit based, if you just change the language in your head while you're reading it, it can kind of just help you to think more about it on a broad spectrum a lot. I do that a lot, so that helps too.
Really
Thank you. I'll start doing that now.
Very kind of closely linked, you know, another attendee saying they can really see a rationale for not using ADOS with older teens or children. But in terms of using a report, of writing a report without using ADOS, is there any practical issues that might arise, and a particular reference to, for example, issues with the HSE recognizing a diagnosis?
No, there is no. In the best practice documents, it says that there needs to be a standardized interview tool, but you don't actually have to have the ADOS. So if you do a really thorough, I mean, we you know, I haven't done the ADOS with a teenager in a very, very long time. I wouldn't do it. I wouldn't put it through them. It's actually really uncomfortable, horrible experience for a teenager. Besides, you know, all the other stuff. But no, there's never been an issue with a report being accepted where you've done an in-depth assessment and you've done a proper interview. Maeve, you'd agree with that?
I totally agree with that. And the current best practice guidelines, exactly what you say, Davida, talk about that you do your standardized clinical interview, such as the ADA or the DISCO, and a play-based session, but it doesn't specify that it has to be an ADOS. I know those guidelines are being revised at the moment, but that's currently as it stands, so it's well within that. So there shouldn't be any issue at all with HSE accepting or not accepting. And indeed, I know from my own experience within the HSE that we would have many times accepted reports from private practitioners or otherwise where there wasn't an ADOS, but it was clearly demonstrated how somebody might meet the criteria.
Yeah, like you've clearly spent time with that child and, you know, done a proper assessment. It's fine.
We just have one kind of final meaty question before just a little bit of housekeeping at the end. And this question came through quite early in the night, perhaps. It links to the event that's coming up on the 10th of November. But what it's really about is there a pathway for adult assessment? And the question is, if you're an occupational health doctor within the HSE, is there a mechanism in which you can refer an adult for an autism assessment?
No, essentially there isn't. So they're working, the HSC is, they've started the process of developing pathways for adult autism assessments within the HSC, and it's very, very needed. And there are pockets, there are isolated pockets where there is sometimes adult assessments happening. And if the person is already linked to an adult mental health team, for example, they can sometimes access the assessment through there. But in terms of public pathways, no, there isn't a public pathway at the moment. Yeah.
And there's no referral pathway. I suppose the pockets where that's happening is by chance, really, I guess, you know, in terms of, you know, the clinician who's working with somebody, you know, or a team who's working with somebody doing or recognizing that assessment, but that person wouldn't have been referred in for an autism assessment. It would have been for something else, and then that happens as part of it. So there's no specific pathway as far as I'm aware.
No. But if you're working, I mean, I'll let Tara would probably have a lot more to say about this, but you know, if you're working with an adult that you think might be autistic, they can do a lot of exploration themselves, you know, and self-identification is hugely accepted within the autistic community. Tara, do you want to hear?
Yeah, completely. It is, because of all the barriers, as you're seeing in Ireland and worldwide, and barriers to do with being members of different minorities, whether there's gender variance involved, and you know, I suppose race. There's just so many differences that mean that somebody will not get a diagnosis easily. So there's we work with so many adults worldwide who are struggling to get diagnoses, but there's so much wonderful work can be done with self-identification. As you said, it's really wholeheartedly accepted across the autistic community. There's wonderful peer support groups, lots of amazing grassroots organizations and autistic-led organizations, including ourselves, out there supporting autistic adults who have not got formal diagnoses. So yeah, but unfortunately, as of yet, but I mean, we're all working to change that, and it's wonderful to see, even though like here in this webinar series, we've had a mixture of private practitioners and HSC staff members, and then non-profit organizations, and everybody working towards the common goal of human rights for neurodivergent people, including getting public pathways for assessments and supports. So, you know, everybody here is here because they want to make a difference. So it's great. Keep in touch. We'll keep moving with it.
So now, just for an opportunity for a little bit of a shameless promotion again at the end. So there was a question from somebody who has really enjoyed the webinar series and really wants to attend the talk on the 10th at the PSI conference. They can't attend, but I guess they have two questions. Will it be you guys presenting? Number one. And number two, what if you can't attend? Is there any way to access the talk?
It is us and Juliana, because we're the authors of the book that's coming out. You probably have to be a member of PSI to attend. I don't know, is it being, yeah, I think it is being recorded, but we do a lot of these, we'll be doing very similar. I'm almost positive, Tara, I can't remember. I think it is being recorded. I'm not sure if it's going to be widely available or not.
It is being recorded.
Is it going to be made available publicly?
I don't know.
We don't know.
But we do loads of these trainings, and if you want to make a change happen in your team and you want to get funding for us to come in, we'll happily do that too.
yeah, exactly. No, we do a lot of, we'll definitely be doing more webinars in that area, you know, if it isn't made available. You could ask the PSI, maybe email the PSI and ask them.
Just to close out, some people were wondering about, will the slides be available from this evening? And a lot of people wondering, is it possible to get a copy of the reworded DSM-5 criteria? So they're just two questions someone might answer quickly.
Yeah, no problem. Slides will be available, video will be available. We're going to be putting together a pack of what we were talking about, and I will make a note, DSM-5 reworded, yes. Done.
Well, that is all that we have time for this evening. I want to sincerely thank our wonderful panel of contributors, Davida, Maeve, Tara and Jess, for educating us all this evening and sharing their knowledge so generously. We look forward to getting the resources out to you as soon as possible, and have a good evening, everybody.
Yeah, and sorry, we forgot to add that there's the survey coming up now at the end when we finish up, but we'd be really grateful. I know you're probably all tired and wanting to switch off, but it would be great to hear feedback so that we can improve future.
3 minutes is all it will take.
Really quick. Thank you so much, everybody.
Thank you.
Thank
Thanks,
you.
everybody.
Thank you, Adam.
No problem at all.